Oh yeah, there we go.
Good evening, web shadowers, and welcome back to our second session of the fall 2021 semester. We'd like to thank you all for joining us tonight. We have the pleasure of hosting Dr. Shah again, who will be teaching us all about PM&R.
And as always, please remember that the Google form will be posted in the chat box at the end of the session, and it'll also be in the description of this video. With that being said, Dr. Shah, you may start whenever you're ready.
Cool. Awesome. Well, thanks so much for having me back here for round two. I know round one was awesome and exciting. Oh, I can hear the live through my phone. That's okay. There we go. But yeah, thanks so much for having me back. Hello, web shadowers. Again, I'm going to keep this kind of open. So if you guys have any questions whatsoever as I go through this case, feel free to write in the question box. I also got YouTube open so I can see the YouTube comments coming through as well. Again, I'm Dr. Shah. I am a PGY2 in physical medicine rehab at Penn State Hershey. So we'll go through this case, and it's not going to be a really long case. So if there's questions afterwards about the case or anything kind of pre-med, I'd be more than happy to do that, as I do a lot of pre-med coaching as well. So let's get started here. Okay, so this is a case I actually saw about a month ago, and I submitted it as a case report to one of our major conferences because it was that interesting. So a paradoxical case of neuropathy, right? And what is neuropathy? Neuropathy is something that is kind of like nerve pain. And there's many different diagnoses that come along with it. So keep your differentials broad, keep your thinking broad, and let's get it rolling. Okay, so the history. So this patient was a 75-year-old female. Her only significant history was lumbar scoliosis. So she had curvature of the spine in her lumbar region. She was admitted to inpatient rehab, because again, physical medicine rehab, that is where we work. And she came in because she had a 6-month rapid decline in neurological and motor symptoms. So what were those symptoms? She had lower extremity weakness as well as sensory loss. Okay, so you can imagine her upper body is completely fine, but her legs are getting weak all of a sudden, and she doesn't have great sensation. So when you touch her, she sometimes says, I don't feel that at all. Or if you really push deep on her for deep pressure, I don't feel that at all. And the result of this is something called ambulatory dysfunction. So she basically has trouble walking. And so that's something classic that we deal with in PM&R is older patients having difficulty walking. And we kind of have to figure out why. Is it a muscular issue? Is it a neuropathy like this might be? Is it because they just lay in bed all day and they don't really walk around and they don't have the muscle? So those are kind of the things that we're thinking about. Now, what's interesting, though, is that this was a 6-month rapid decline, okay? So previously, she was independent completely. She could walk on her own. She had no issues. She was essentially a healthy 75-year-old. So before she got admitted, she actually got an MRI of her spine. And what the MRI revealed is a C4 to C6 spinal stenosis. So you can imagine C4 to C6 is your cervical spine, and spinal stenosis essentially means narrowing. So her spinal canal narrowed. And what that can often do is kind of impinge your nerves. So a lot of you guys might have heard of sciatica, which is nerve pain going down kind of your butt and then to your legs. And a lot of people get this with herniated discs, for example, or lumbar stenosis. So in her case, she has spinal stenosis in the cervical region. So typically with that, you would see more upper body nerve pain. And then she also denies headache. She has no chest pain. She has no shortness of breath, abdominal pain, fevers. And again, we ask all these questions because you never know. And one of the keys in medicine is when you have different symptoms, you kind of want to put all those symptoms together and figure out if there's one diagnosis that can classify all those things. Often early in your career, if you guys are going into medical school or PA or whatever it might be in healthcare, you're going to find yourself having different diagnoses for different symptoms. But as you get more experience, you're going to try to want to put all those things together. So that's why we ask all those questions. Okay, so, oh man, this was not supposed to happen like that, but okay. So here's some differential diagnosis. And this text was supposed to be hidden, but I guess it didn't happen like that. So the way we want to think about this, right, is when somebody comes in with such a broad symptom, like difficulty walking, what different systems in the body could play a role in that, right? So obviously we think about the nervous system. She's complaining of nerve pain, essentially. So we think about the central nervous system, right? She's a female, she's white, and she's older. So we think about multiple sclerosis. Typically, you see that in about the 40, 50-year-old white female, but you never know. It could, definitely pop up and still affect people later on in their older years. Brain tumors are something to think about, as they can, impinge on something in the brain, and that can cause some weakness. A spinal cord injury can definitely do that. Again, typically, you'll get more severity than just a stenosis. And then Parkinson's, right? So people who have difficulty walking, if they have a specific walking pattern, like they shuffle their gait, you want to think Parkinson's, and you want to look for other symptoms of Parkinson's, like a tremor, for example. So aside from the central nervous system, right, which is just the brain and the spine, we want to think about the nervous system in the extremities. So the legs itself, the arms, things like that. And so we have neuropathy, which you would diagnose with something called an EMG. So essentially you're putting needles into the muscle, and that would essentially tell you if there's something kind of wrong with that nerve. Something called Guillain-Barré syndrome, which you all may have heard of in terms of vaccine adverse effects, right? So it's definitely an adverse effect of a vaccine that some people can have. And actually next door to this patient was a patient with Guillain-Barré. And again, it doesn't only have to happen because of a vaccine side effect. But essentially with Guillain-Barré, there's something called a glove and stocking distribution. What that means is gloves, so the hands, and stocking, so your feet, ankles, and above. And that's where you'll get some loss of neurological or motor symptoms. We also want to think autoimmune disease, right? So this is something that's so common. Is there some sort of thyroid dysfunction? Should we check the thyroid? Myositis. So again, itis, that suffix means inflammation, and myo means muscle. So is there something wrong with her muscle? Do we need to check certain labs for that? And then multiple sclerosis, again, can also be something that's autoimmune. Then we want to think musculoskeletal. So the bones, the tendons, the muscle itself. Does she have a fracture? Does she have a sprain or a strain? And those are things that you can do with a quick exam maneuver, or even get x-rays. And then you never want to forget about metabolic disease, right? So things like B12 deficiency, vitamin Bs, vitamin A, vitamin E, all these things can kind of play a role in terms of giving you good nerve health, and dementia. So you'll often see people who are demented also have trouble with walking or trouble with balance, because you honestly need good coordination and understanding of motor planning in your head to understand what's next. And if you have memory loss, or you're not really thinking properly, or you sundown, where at nighttime you get very agitated and almost like an alter ego, you're going to tend to not walk as much. You're going to tend to be more bedbound. And so that result of that is ambulatory dysfunction. Let me see here on the YouTube if there's anything there. So I thought MS was mesolimbic brain tumor. So MS is not necessarily a tumor, right? So it's more of lesions in the spinal cord or in the brain. Okay, so physical exam, right? So this is PM&R, bread and butter. Your physical exam is going to be the most important thing you do. And this is what we pride ourselves on. So generally, very pleasant, cooperative woman, not in any distress, right? So she's not writhing around in pain. This is something that only brings her pain as she's walking or doing any type of activity. HEENT, so your head, ears, eyes, nose, and throat, everything normal. Her eyes are intact, right? So if her eyes weren't really functioning like I'd expect, and I'm thinking, is there something in the brain that's getting impinged, like a nerve or something? Perla just means pupils are equal, reactive, and round to light, and they also accommodate. So eyes are essentially okay. Cardiovascularly, regular rate and rhythm. The MRG stands for no murmurs, no rubs, no gallops. So her heart sounds normal. Pulmonary, CTAB stands for clear to auscultation bilaterally. So when you listen to her in the anterior fields as well as the posterior fields, she sounds completely fine. Her abdominal exam is normal, so non-tender, it's not distended or out. Her bowel sounds are normal. And now this is where we really get into the thick of things, right? Extremities and looking at the neuro exam. So her extremities, so surprisingly, she has almost 5 out of 5 strength in all her extremities, right? And so when we grade strength, we grade it on a system of 5. And the way you kind of think about it is a 3 out of 5 means that the patient can move it on their own against gravity. When you get to a 4 out of 5, it's essentially when you resist them, they have somewhat of some resistance, and you can feel that muscle moving. A 5 out of 5 is essentially full strength though. So it's interesting, right? So when we think of people with ambulatory dysfunction, we want to say, is it their strength that's limiting them? Is it because their strength that they're unable to walk their usual selves? And in this case, it wasn't. And then she also has full passive range of motion. So again, sometimes in elderly patients, you're going to see arthritis, right? Or hip impingements. So their joints won't move to the full capability, and they'll be limited in some way. Now, neurologically, her cranial nerves were intact, right? So all the cranial nerves in the brain that kind of affect all the facial function are intact. She has a slight decrease in coordination though, right? And coordination is kind of all about your cerebellum, right? So your mini brain. And so one way we test that is kind of, we tell them to touch their fingers in order as fast as they can. And for her, it was kind of slow, and then she'd get it after a while. So that kind of points to something. She's hyperreflexic, right? So in this case, we take a reflex hammer, and as you guys all know, you hit that patellar tendon right in the knee and you see it kind of jerk up. Well, for her, she went super fast. And so what that kind of points to is there an upper motor neuron syndrome? So is this a spinal cord lesion maybe in her spinal cord or brain rather than something just in her legs? And then when we had her walk, she would walk a couple steps and then it was almost as if she forgot how to walk and her foot would just slap down and she would lose her balance. And that's where a lot of the safety concern was. So again, a very interesting kind of case where imaging didn't really tell us anything, right? Because we got an MRI and all it really told us was spinal stenosis, which we don't really expect these symptoms with that. So we got labs, okay? So a CMP, complete metabolic panel, right? So this kind of tells you your sodium, your electrolytes, your kidney function, which is the BUN and creatinine, tells you your liver function, right? So these are all within normal limits. And then we also got a CBC. So we got a white blood count, which kind of tells you if there's any inflammation or an infection. That was normal. Hemoglobin, which tells us, are you losing blood or do you have enough blood in your body? That was normal. And then platelets were also normal. So you guys can go ahead and write in the comments on YouTube or wherever here as well. And what other lab tests do you want to get for this patient, right? So think about our diagnoses that we were talking about, that broad differential. Is there anything else? Excuse me, is there anything else you want to get in terms of tests? Okay. So I see one person here writing, how would C4, C6 stenosis result in lower extremity weakness and dysfunction? Exactly. It usually wouldn't. I mean, I wouldn't rule it out, but it usually wouldn't, right? Unless it's affecting the spinal cord, the transmission of nerves from the cervical spine all the way down, right? So that's why, we're not really convinced in this patient at least, which is why I just wrote it here. Remember, the MRI brain and spine only showed spinal stenosis. Okay, so we can get an x-ray, which I think she previously had, or MRI of the legs, which did not show any fractures, no sprains, no strains, nothing like that. So out of curiosity, what's in her spine? Was the scoliosis centered? Sedimentation rate, CRP. So we did not get any of those, like those inflammatory markers, right? So ESR is erythrocyte sedimentation rate, and then CRP is C-reactive protein. Now, those tests are really good if somebody has osteomyelitis, for example, and you're thinking, is there an infection, or autoimmune disease too? I mean, yeah, if we were really thinking autoimmune, that'd be really something that would also be helpful. So let's say in this case, her CRP and ESR were normal. Genetic history for lower extremity weakness. So I'm not sure of any genetic tests that would tell you that, right? So genetic testing is usually good to see if you have any autoimmune diseases, but they're super pricey, right? And when you think of the healthcare model, we have to think of tests that are less expensive, that are higher yield, right? So if we were like complete mystery and we have no idea, we ran through every test, then the patient might say, hey, we need to get a genetic test or something. But before then, we probably have some clues to get the genetic test. TSH is a good idea too. Yeah, we could definitely get like a thyroid to see, a thyroid stimulating hormone to see if that has any effect whatsoever. An EMG. So an EMG would be awesome. And we did not get one because she was in the rehab setting. And I'll tell you why we didn't get an EMG. We also knew the diagnosis that she came in with, right? So we kind of knew what the issue was before she came in. And the reason I'm not telling you guys what it was is because I want to test your brains out here as well. Otherwise, I'd give the answer away. So I had it easy, I guess, when I admitted this patient because I already kind of knew what she had, but still we weren't, and I'll talk about it later, as we weren't fully convinced as to what she had causing her symptoms. Yeah, so an EMG, again, would tell you kind of nerve pain, and it would confirm neuropathy if she did have that. Okay, so could a PET scan help? So PET scan would tell you more metabolic activity, right? So the way a PET scan works is it shows increased glucose uptake, right? And if you guys know about cancer, cancer cells are very active, right? They have a high metabolic rate. And so what does that mean? They use glucose. So that's essentially what you would use a PET scan for, is to kind of show you where tumors might be or cancer. Spinal tap. So she actually, did she get a spinal tap? I'm trying to think here. She did get a spinal tap, I believe, and it did not show anything. She got CSF fluids and like serum analysis, did not show anything. So these are all great ideas. So let's keep going here. So vitamin panel, right? So we kind of talked about this. So nerve health, you want to think vitamins as well, right? As much as we like to think that there might be something that we can touch and feel, like a fracture or a sprain, or something that we can see evidently, you also want to think about the things that you can't see but still affect these things, right? Like nerve health or bone health. So a B12, right? You guys may have heard of how important B12 is now and why they're recommending everyone taking it, right? In medical school, you learn if you're a vegetarian or vegan, you need to take a B12, but our soil in the US is so depleted of nutrients now that they're recommending kind of everyone take B12. And it's interesting because I am a vegetarian. And one of the questions I often get, even today, my attending asked me, how do you get your B12? Well, I take a supplement, but everybody should be taking a B12. And what you realize is you'll see a lot of B12 deficiency in the hospital. And those patients aren't vegetarians. I mean, a lot of them eat meat. So B12 in an elderly patient, you want to think of, because that could be something that could affect your nerves. But in this case, it was normal, right? B1 is something else you want to think of, could definitely affect your nerves. This is something you kind of see more in alcoholics, encephalopathic patients, so patients that are altered in their mindset, but normal for her. Folate, another one that's crucial, right? And a lot of times we talk about folate in pregnant women, or we talk about folate in anemic patients who have low blood levels. So we checked it on her, normal as well, right? Interestingly, her B6 was super high, right? So usually we think of B6 deficiency, right? And there's a lot of medications out there that can cause a B6 deficiency, but she had a high B6. And so that when she came in with that was something that intrigued us, because we said, what are the symptoms of B6? So this is something that we started to look into. We looked into research and all that. And as you can see, a normal level of B6 is less than 50, but in her, it was 220. So I'm just kind of reading the answers here. So what about drawing magnesium levels? Absolutely. So we definitely draw magnesium levels on almost all our patients, because that can definitely also kind of affect things, not so much the nerves as much, but more of sleep and the heart and things like that. EEG. So, I mean, you could if you're thinking seizures, but otherwise we usually don't do EEGs right away. What are symptoms of B12 deficiency? So I kind of just went through that. So, okay, B6 is very high. So could this be it? Okay, and the reason she had a high B6, let me explain, is she was drinking a lot of Ensure. She was having she was essentially eating a lot of B6. So when you guys work in the hospital, you'll see that a lot of the patients who have poor appetites, the dietitians, the nutritionists will put these patients on supplemental kind of shakes, right? Those Ensure, those Boost shakes, things like that have high protein and good nutrients. Well, she was like chugging down 2 a day, 2.5 a day, and also supplementing. And essentially, we don't know why, but her body wasn't clearing out the B6. I mean, usually, what do we say? You take a multivitamin, and if you have excess of those vitamins, you just pee it out, right? And that's what makes your pee bright yellow. But in her case, I don't know, her B6 just wasn't getting excreted, I guess. So kind of stayed up there. So let's talk about vitamin deficiencies, right? So kind of went into this. So you want to take a look at vitamins whenever you are thinking of a patient with neuropathy or with neurological symptoms, and you don't have anything that you can see to explain it, right? So you obviously want to get the tests that you guys were all mentioning first, right? The X-rays, the MRIs. You want to look at autoimmune kind of things. You do want to look at those things, but these tests are also cheap, right? Like these tests do not cost a lot of money. It's an easy blood work test, and you can get a lot of your answers from there as well. Now, just because they have a low B12 or low B1, low folate or low vitamin deficiency doesn't necessarily mean that that is what's causing their issues, right? So you still have to go fishing. But if you've kind of done your homework and you're like, this seems like it's it, like this is really low or this is really high, then you try to correct that. And if it gets better with correction, then you kind of have your answer. So in this case, the reason I named this case paradoxical is because a high B6, right? And this is very interesting because vitamin deficiencies don't act like high, like vitamin toxicity, right? So if you have a low B1 and a high B1, they're not necessarily going to act the same. If you have vitamin A toxicity versus vitamin A deficiency, also not going to act the same. But in the case of B6, if you have a high B6 level, you're essentially causing your body to have a low B6 level. And that's because B6 has so many different analogs, right? It's like, honestly, the only way I can think of this is like CBD or THC in medical marijuana, right? Because THC has so many different forms, CBD has so many different forms, and they all bind to different receptors. And this is the same thing with B6. It has so many different forms. And so the B6 that she was ingesting was actually inactivating the active B6 that your body uses, right? And so in a way, even though your blood shows that you have high B6 levels, your body's acting as if it has low B6 levels. Okay, so let me see here if there's anything. If someone has lower B12 than normal, than 200, are they deficient? So it's interesting. Yeah, B12 depends on the hospital you go to. That shows a range, right? And again, I'm very much about individualized medicine. So it's important to realize that just because you have a B12 that's a normal range, but on the lower side, it could essentially affect you as a deficiency, right? So I think it's important to have a good level of B12 and not just be in the normal range. That's essentially for every vitamin. And again, it's going to be individualized. Like I've had patients who've had nerve pain, normal B12, but on the lower range. And I've had attendings tell me and be like, just because they're normal doesn't necessarily mean it's normal for them, right? And so this is what you'll learn at kind of in the hospitals, that we're treating the masses, right? And when you have to look at data, you have to get a wide range, because the more we narrow that range, the more issues we then start to treat when we don't necessarily need to. Okay, and they love giving Ensure. Yep, geriatrics for Ensure and Boost. That's all you'll see. So again, I mean, those are great products. There's a heavy sugar in them, but a lot of times patients who are wasting muscle or losing weight, you want to give them Ensure, you want to give them Boost, because there's so much nutrients in them. For some reason in her, it was just causing a high B6 level. So the B6 operating under negative feedback. Yeah, essentially. So yep, there was an analog of B6, and it was just basically binding to the receptor or inactivating that active metabolite. And so you have a paradoxical deficiency. Okay, so vitamin deficiencies, right? Let's kind of broaden it now and kind of discuss what these different vitamins do, right? So vitamin A, you guys probably know this, carrots, right? It's great for eyesight. It's great for your retina. Vitamin A deficiency, I think, is actually the most common cause of blindness in the world. Don't quote me on that, but I'm pretty sure that's what it is. And again, in the US here, we're lucky to not really have as much vitamin deficiencies as other countries in this world, right? So you go to other third world countries and things, and these type of vitamin deficiencies are things that you will see. So vitamin A, you will actually hear it more in the context of toxicity and how it can affect the liver more so, right? Or you'll hear it in terms of retinoid toxicity and things like that with vitamin A. Vitamin B, we kind of just talked about a little bit. So, if you have a B1, B2, B3 deficiency, things like that, encephalopathy, again, altered mental status, nerve pain, neuropathy, you can get some rashes as well, especially if you have a B2 deficiency. You can start to see a rash near your lips here. Vitamin C, right? So scurvy, this is why sailors used to have like lemons back in the day. So vitamin C is also very important in helping collagen, so wound healing. Vitamin C is also kind of growing now more into the field of cancer. So a lot of solid tumors that can't really get penetrated, they're seeing that high doses of vitamin C might actually penetrate these tumors. So interesting stuff. And then vitamin E, super rare. You'll also see some neurological symptoms and whatnot. Vitamin E is actually, I believe, used in the vaping cartridges. So a lot of the oil is vitamin E. And so you actually don't want to smoke that vitamin E as it's toxic. And then folate, again, pregnant patients. The reason we do this in pregnant patients is that if they don't have great folate, the baby can develop spina bifida, more neurological kind of deficiencies and things like that. So advice, right? This is where they tell you to eat your veggies and fruits, right? That's where all the nutrients are. And again, I really want to go into lifestyle medicine, functional medicine, things like that. And it's just very interesting to think that, an apple that you would eat probably about like 60, 70 years ago has so many nutrients that it's probably equivalent to about like 6 or 7 apples in today's world. So that's how much our soils are getting depleted in terms of the vitamins that we need. And so again, when you guys get into your careers, keep these vitamin deficiencies in the back of your mind. People, I'm sure as you guys know, the obesity rates are through the roof, right? And why is that? Well, people aren't eating nutritious foods, right? And especially as you get older and you're less active and your intake goes down and you start to eat more like crap, you're going to start to see these deficiencies. Even with just like farming in our soil, like I said, again, most of the world is like in a vitamin D deficiency, even B12, magnesium. These are all things that are getting more thrown into personalized medicine, but I think should really be talked about as well in terms of healthcare for the masses, right? There's a lot of correlation between vitamin D and COVID, for example. So, take your multivitamins. Obviously, you want to get these with fruits and veggies and, natural foods. So, and then, right after I submitted this case, I actually had another patient that came in with vitamin B6 deficiency. And so we ran almost every test with this patient, right? So he came in as an alcoholic and he was actually in an inpatient internal medicine service. And they ran B12, B1, everything. And everything came back normal. And so the one thing we realized they didn't check was B6. And so we got a B6, and that was the one vitamin that was low in this patient. And so I supplemented him back with B6, and it seems like he's doing a lot better now. I haven't kept close eye on him or anything. But it just goes to show you that like one of these things could be the biggest difference. And again, like I said right there, B6 is one of the things that people don't really think about as much, but B12, B1 are more common. So let me think. Yeah. So if you guys have any questions about this case or anything, go for it. Let me read these here. Interesting. Wow. Are deficiencies due to lack of intake or lack of gut microbiome diversity? Oh, wow. That's an awesome question. So yeah, both. In conventional medicine, you're probably going to learn more that's intake. If you go into the functional lifestyle medicine route, you're probably going to learn more about the microbiome. Again, autoimmune disease as well, right? Like, so B12 isn't always because of intake. It could be you have intrinsic factor deficiency, right? So your gut might not produce something that actually binds to B12. In a lot of patients, they might have a section of their small intestine taken out. And we know that the small intestine can absorb, iron and folate, things like that. So yeah, it plays a huge role in terms of your gut microbiome and making sure that it's healthy. The more bad bacteria you have or things like that, you might not absorb as much fat, for example. And we know that vitamins A, vitamins D, E, and K are fat soluble, and the vitamin Bs are water soluble. So all these play a role. And one of the things you kind of learn in lifestyle functional medicine is if you don't reset your gut microbiome to optimize it, and you take multivitamins or you eat organic and a lot of healthy stuff, well, you might just be making expensive poop, right? Like you actually might not be absorbing all those things. B6 also helps to cope depression. It might. I mean, I wouldn't doubt if it didn't. I didn't really read any literature on B6 specifically for depression, but I mean, all these vitamins can do anything to anyone, right? And the body is so nuanced and complex, right? And I think that's the biggest thing I've come to appreciate about medicine is that we're all trying to figure out data and science and research papers and trying to figure out one-to-one links. But while there's a lot of good stuff out there, we have to remember that we're never going to know everything about something, right? We only know something about something, and we have to keep pushing and moving the needle forward. We have to keep learning about these things because again, the body's so complex. I forget, I was on Instagram one day and I saw somebody just put like one of these diagrams out there and say, this is how complex the body is. And it was just all these biochemical processes pointing to one another. And it was just like, you didn't even know where to start or where to finish. And that's exactly what's happening. Your body's doing all these things at the same time. And the medications you take, the food you eat, everything is operating on different systems, and all these systems are talking, right? So it's fascinating. And again, I think that's why there needs to be a push for more personalized medicine. Other than B6, are there any other vitamins, minerals where a high amount acts like a deficiency? I don't know of any. I'm sure there are some. I'm sure the B vitamins do that in general, but I don't know of any like right off the bat. Could you expand on resetting the gut microbiome? Yeah, absolutely. So, I mean, a lot of people try to take probiotics, right? Thinking that probiotics are going to help you bring in good bacteria to your gut, right? And we need to understand that there's bad bacteria in the gut, right? That's damaging. And there's good bacteria that are helping your body flourish and keeping that immune system intact. And again, probiotics don't have any data really behind it. But eating a lot of fiber, right, can definitely help you because it's going to create short chain fatty acids in your gut microbiome. And that's going to cause the tight junctions in your gut to kind of stay tight rather than loose and allow toxins and other things to kind of bypass. And so when you hear the term leaky gut, that's what people are kind of referring to as intestinal permeability. So when I say reset the gut, I kind of mean getting your gut microbiome optimized for yourself, for you. And it's tough to do. I know a lot of doctors out there are doing stool samples and they're trying to see the profile of your gut, but that's not necessarily individualized as well, right? I mean, it's hard to know how my gut is optimal for me versus yours. And our gut microbiomes are like fingerprints. They're different for everybody. But it's pretty much known that your gut is the operating system, right? It has so much control over gene expression, as do the foods that we eat. And so that's why a lot of people in lifestyle medicine things will start with the gut. If you can heal the gut, you can heal a lot of the other things out there. Thanks for having an open mind, exploring functional medicine. Absolutely. We're at a time right now where people are kind of splitting ends, right, with everything. And again, I think we all need to come together and realize that we're all kind of have the same goals in terms of helping patients out to living their best lives. And in order to do that, you need to combine conventional medicine with lifestyle medicine, functional medicine, Eastern medicine, Western medicine. Like everyone has a role to play. And when you can put your mind together with all these things, I think you're going to start to see better results for your patients. Can you explain why supplementing vitamin D and K are correlated? So that has to do more with calcium. So when you take vitamin D, it has a major role in calcium. And so one of the thoughts out there is that as calcium gets reabsorbed from your bone into the blood, it can cause sclerosis. So, it can cause coronary artery disease, for example, if it creates a plaque. And what vitamin K does is that it allows that calcium to stay on the bone. Now, I'm not sure about the exact mechanisms behind it, but that's what I relatively know about it. So I take vitamin D every day, about 1,000 units. I don't take vitamin K with it. It's just, I don't know. I'm not sure what the data shows as when you should start taking vitamin K with D. Is a fecal transplant a potentially clinic treatment for chronic deficiencies, or is that more so just for other sorts of dysbiosis? Yeah, it's more for dysbiosis. So fecal transplant, I have yet to see it. But yeah, it's more so for people who get like recurrent Clostridium difficile, right? So if you're getting a lot of C. diff infections, last resort is like fecal transplant, right? Like it's very rare to see it happen, but it's literally just so. What's fascinating and what you guys should all read on is how people's gene expressions have changed after fecal transplants. Super interesting, right? Because now we know that, hey, the gut is not just the gut. If I give somebody else my microbiome, it literally changes everything about that person's body, even to the like immune system. So there's definitely a lot of papers out there on it, I believe. So that's something that's super, super interesting. Let's see. What should pre-med students look to? Here, let me X out of this and let me see if, I guess I'll stop share. And then we'll still be live. Okay. All right, cool. We're still live. Okay. So let's see here. What should pre-med students look for when applying to a med school? And do you know any schools that are great for infectious disease medicine? So let me answer that second part, right? So infectious disease medicine, I don't think you're going to find a school, for example, because what you're going to learn in med school is essentially just all the pharmacology, all the microbiology, virology, all those things, right? Infectious disease and looking for that would be more of a fellowship, right? So you want to look for a good internal medicine program that has a good fellowship into infectious disease. What should pre-meds look for in terms of med school? There's no such thing as a bad med school. That's the first thing I'll say. So if you get into a med school, awesome, right? Like you're going to become a physician most likely. Things that matter though are subjective, right? So geography probably matters, a lot. So that, location, if you are in a relationship with somebody, right? If you want to be closer to them, if you want to be closer to family, if you want better weather, things like that. Other things that matter are, do you want to go to an osteopathic school? Do you want to go to an allopathic school? Other things are, do you want to go to a top tier school with a lot of research that you can do, right? Are you thinking MD, PhD, or do you really just want to go to a school that is, more osteopathic, that doesn't have a really big, that doesn't have a lot of research, but you can do a lot of clinical stuff. So those are really the things that I'd say. I would tell everyone to apply broadly. I don't think you can go wrong with applying broadly. You want options, and medical school applications and getting in just gets tougher and tougher, right? Because we're seeing so many more and more applications coming in, especially now. So they called this the Fauci effect, which I think has nothing to do with Fauci during COVID, but we saw a huge increase in the bump of how many students were applying. And a lot of them were trying to say that it was because they were inspired by Fauci, but it's because we're in a virtual season, right? So people can pay less, but they can apply to more schools because there's no traveling. Also, a lot of schools weren't taking MCAT. So you have to put that into picture too, saying that it's going to be more competitive nowadays. People are applying more, especially if we're staying in a virtual environment. So, okay, let's see here. Taking OChem and physics this year, third year of undergrad. I still want to apply to med school this year, and I'm planning to take my MCAT in September. Thoughts? So again, you got to do you. My thoughts are take a gap year. I would tell everyone and anyone and everyone again to take a gap year, at least one. I just think there's so much to learn and so much to mature. And I'm not saying all you guys are immature out there. I know I was, but you got to realize that the brain doesn't fully develop that frontal cortex until you're 25 years old, right? And that comes into future planning. And so I went to a BSMD program, didn't make it through. Essentially, I got rejected twice to medical school, forced to take a 2-year gap year, and then finally got in. It was the best thing that actually ever happened to me. I mean, having life experiences, doing great research, figuring out myself, and then realizing why I kind of wanted to go into medicine, like truly, and working for that helped me become successful in med school and even now. And if I didn't have those, I probably would not be where I am today, at least. So consider taking gap years. I don't think there should be a rush in terms of going to med school. The average starting age of a med student is 25 as it is. And if you ask anyone who took a gap year, you will probably never hear someone say they regretted it, but you will find the opposite to be true, where people go straight through and they say, man, I wish I took a year or two off. From my understanding, med schools don't teach nutrition enough. Is that true? That is 100% true. And so I have a podcast called Medicine Redefined, and we talk about nutrition on there a lot. And one of the common themes with our guests is, why do we not learn this? I think you might get like 1 day's worth, like 24 hours worth of nutrition. I think that's the average, is 23.9 or something. Yeah, you don't get it taught enough. I mean, it's because we have nutritionists in the healthcare system. And so we believe that it's their responsibility, but oftentimes you don't work with them, enough. And if you're interested in wellness and lifestyle medicine, then those are things that you're kind of going to have to learn on your own, unfortunately. So yeah, you definitely don't learn enough nutrition in med school. Okay. Is that from epigenetic changes or more protein signaling? I think all of it, right? So I think the biochemical pathways change, right? And we're going back to fecal transplants here. Your microbiome do gene expression, right? So you're automatically going to have some sort of epigenetics there. You're also going to have some sort of protein signaling with the immune system, right? So you're also affecting the hormonal system. We know that there's a gut-brain connection, right? We know that there's a trifecta as well with your adrenal. So your sympathetic system is connected to your immune system, right? Your sympathetic system's connected to your brain, and your brain's connected to your gut. So now you guys really appreciate just how freaking complex the body is, and how the gut is almost the command center for all these things. Today we talked about Wernicke-Korsakoff. Yep, B1 deficiency. How does a difference in just the number from like B1 to B6 change how a patient presents? Well, they're doing different things, right? So B1, I'm guessing, yeah, it's more encephalopathy, which is why you're going to see it more common, right? You're going to have a lot of alcoholic patients come in. B6 deficiencies, you really see from medication side effect, right? So something with the liver and it's not allowing B6 to convert into its active form or something. So those are very board relevant things, but you don't see it as much in clinical practice because doctors know about these side effects and they tell patients, hey, when you're on this medication, we're going to test your B6, or when you're on this medication, we're going to make sure we give you B6. Whereas alcoholics aren't getting healthcare in general, right? They're kind of not following up with doctors. So before it's too late, their deficiency is already in place. And then you get something called Wernicke-Korsakoff syndrome, which again is a lot of confabulation, a lot of encephalopathy, and something you'll definitely see in the hospital setting. Having an electric sensation in your feet is associated with any vitamin or something else in the neurological system. It can be anything. Diabetics have a lot of nerve pain in the foot, right? So if somebody tells me, if this 75-year-old had diabetes and said, I have pain in my foot, I would 100% think nerve pain, right? I'm going to say that's probably nerve pain. But it doesn't have to be that, right? It could be a nerve is entrapped by a bone or the muscle, or there's a fracture or a sprain. I have a patient right now who has just pain that she can't describe in both of her feet bilaterally, right? On the soles of her feet. And her arches are literally like this on her feet, almost as if she was like a ballet dancer or something. And she's like a 90-year-old. And we don't really know what the pain is because it's hard for her to describe exactly what she's feeling. So again, kind of nerve pain, neurological pain, all these things, you gotta, again, that's why I had that one slide. You gotta keep your differential very, very, very broad and start to narrow it down based off kind of tests or symptoms that they bring up, different medications you give, and if they don't work, then you can kind of rule out some things. Could you please elaborate on fibromyalgia and reasons behind it? That's an interesting one, right? So conventional medicine will teach you that fibromyalgia is almost a mental health issue. It's almost fabricated pain where these patients just are in pain, but there's no real cause behind it. They just mentally are kind of in pain. And I think one of the most important things to realize is in fibromyalgia, and we don't even understand pain. Like pain is such a nuanced topic that we still haven't even touched the iceberg or the tip of the iceberg in terms of receptors or the pathways of it and things like that, right? In the brain, how it all works. So to dismiss somebody with fibromyalgia and say, you don't really have this pain, it's kind of BS, right? It's BS in the opposite way, that this patient's experiencing pain and it's a very subjective experience. And what if you guys know of John Sarno's work, he's somebody who essentially said that all back pain is in your head. And there's a huge mental component of pain. And we all know that. We all know there's a huge mental component of pain. We actually brought a guest onto our podcast to talk about pain and sleep. And if you don't get a great night of sleep, your pain sensitivity goes up. And when your pain sensitivity goes up, you don't get great sleep, right? And now it's kind of this chicken or egg. But we know that it's related. And we know that if somebody gets really good sleep, their pain threshold goes up, right? So they're not in as much pain. So again, there's so many factors behind it. But the worst thing we can do as a healthcare provider is to just tell somebody that it's in your head. And sure, the pain's actually in their head because they're actually feeling it. But we got to figure out ways to give them cognitive therapy, to get them to move more and exercise, deal with that pain, teach the brain that this pain is okay, right? And we're slowly getting there, as healthcare providers. But I think it's just a huge lesson for all of us to learn, as we go into this. And we're going to see people with pain, and it's going to be difficult to diagnose. And, a lot of times we just want to be like, I don't know what to do. Like, you're honestly making this up. We can't find anything. But the biggest thing to do is to kind of stick with those patients and really just help them cope. Would functional medicine, lifestyle medicine be something med students could specialize in during med school? So lifestyle medicine is technically something that you could get board certified in as you go through residency. So if you go to a program that has lifestyle medicine, or you talk to the American College of Lifestyle Medicine and bring the program to your current residency program, you have the opportunity to get lifestyle medicine boarded right out of residency, which is awesome. Functional medicine, unfortunately, you cannot. There's no board certification for it, right? And again, I say functional medicine, a lot of people out there have probably heard, oh, this is voodoo medicine, this is not real, this is quackery. And I'll say, yes, there is a lot of quackery in functional medicine. There's a lot of quackery in conventional medicine. There's quackery everywhere. But what you have to understand is you got to take the best out of everything and form it into your own, right? So we can't disregard all of functional medicine. We can't disregard all of lifestyle medicine. The problem with functional medicine is that there's not a board certification for it, right? So almost anyone can do it. Whereas in lifestyle medicine, you can get board certified. If you do integrative medicine, you can get board certified. So there's some sort of censorship at least. Whereas functional medicine, there isn't, right? And this is why it gets a bad rep. But I've worked with functional medicine doctors who have done emergency medicine for 20 years and then are now doing functional medicine. So I've seen my fair share of conventional medicine doctors who go over to functional medicine. So again, integrative medicine, you can get a fellowship in after residency. Lifestyle medicine, you can get a board certification or fellowship in after residency or during it. And then functional medicine, you got to do after residency as well. If you guys go to the episode, if you guys, again, go to our podcast, Medicine Redefined, the episode with Micah Yu, it's an autoimmune doctor. He's essentially going to be board certified in all three of these things. And he kind of talks about that. So, let's see, what would you recommend during that gap year? Whatever fuels your passion, like whatever you're interested in, whatever you want to be interested in, right? I don't think there's a right or wrong answer. The biggest thing that med schools care about is that you're jumping from stone to stone to stone, right? That there's a progression, that you're not just stalling and just like hanging out, but you at least have something that you're trying to explore, that you want to figure out. For me, I scribed, so I was an ER scribe. Then I did pharmaceutical outsource. Like I worked for a company that did pharmaceutical outsourcing, so I was a virology lab technician. And then I went ahead and did cancer rehab research. So those were kind of my 2 years on the side. I was driving for Lyft. And then I got to backpack Europe too, right before med school. So, I had a lot of cool experiences. So gap years aren't a right or wrong thing, kind of what you do in them. The biggest thing is that you just explore your interests and you kind of learn more about yourself. And I think that's the biggest advantage going to medical school is, hey, I tried these things out. These are things that excite me. These are things that I'm interested in. These are things I learned about myself. And these are the skills that I grew upon. That's what matters. How are you able to frame you're not getting through your BSMD? I asked because they transfer out of my BSMD. I think that's awesome. They transfer out of BSMD. I don't know the reasons why for that, but I'm not a big fan of BSMD programs because, again, most of them don't allow you to take a gap year. Most of them choose your major for you. You're also stuck in this mindset that you have to do medicine. And I really don't think me as an 18-year-old or most of the 18-year-olds out there know that they want to do medicine. Again, like I was saying, the brain doesn't mature until 25. And to understand what your life is going to be at the age of 33 or 30 when you're an attending is very different than the life you're imagining when you're 18, 19. And your 20s are such a different time, right? Where there's rapid growth happening with your mindset and kind of everything when you think about the future. And healthcare is rapidly evolving, right? In the last 10 years. So when I applied to medical school versus me going to become an attending in about 2 years, it's so different, right? And I think there's a disadvantage in the healthcare system that we all go through that I'm very passionate about. And there's this huge disconnect where pre-medical students truly do not understand what medical school is like. Medical students have no idea what residency is like, and residents have no idea what it's like to be an attending, right? Because each process is so different. But what's funny is as a pre-med, we're doing it to become an attending, right? But when we're pre-meds, we don't think that far. We only think of how do we get into medical school because we know that's the hardest part. Once you're there, everything else is at least going to happen. But how do we broaden our mindset and think, wait, I want to become, this is the type of medicine I want to practice and how I want to do it. If that's my end goal, why am I not thinking about that, right? Why am I not shadowing doctors and asking them, this is how I want to practice. Is it possible? Is it possible to do this, right? And I think that's why so many doctors will tell you don't do medicine. The burnout rate is probably 80%. Insurance companies are kind of taking over what we do, right? And it's because a lot of us go into medicine without truly understanding what we want. And we do it because we think we just want to become doctors. But our reality of actually being a physician is so different than what we expected. And then we have to jump through these hoops, and then you're always concerned about the next level and what it's like, that you don't get to take a step back and just kind of think about the overall journey, if that makes sense. And again, you guys can definitely follow me on Instagram. I do a lot of lives where I talk about this type of stuff and do a lot of pre-med Q&A. So you can definitely ask me on there too, if I don't get through all these questions. I know there's a lot. How important is research experience for getting to med school? So again, people will say it's not required, but I think it's very important now. If you asked me this about 4 years ago, I would say, it doesn't really matter. But now, because there's so many applicants and so many of those applicants getting in are doing research, you have to do research to keep up, right? And again, it's kind of a game, which is sad, but I think it is important because you're competing with people who already have it. And so you kind of have to do it yourself too. I am applying to 2023 cycle. I reviewed statistics for Hispanics who matriculate to medical schools, which are low. Any suggestions for minorities to make sure I am successful in applying for resources? I unfortunately don't, but what I would do is reach out to other minorities through social media that are probably where you want to be, right? And you kind of want to follow their footsteps in some way and ask them what they did. I think one of the things that we often underutilize is social media for the good, right? And trying to connect and network with people. Most influencers or people on social media are out there to help people. So don't be afraid to reach out to people on social media and say, hey, do you mind helping me on this? And if the worst thing that you get is either no response or no, and you kind of just ask the next person. But getting other people's opinions is super important, right? Because I was a BSMD and because I had gap years, I'm a huge advocate for gap year. You're going to hear different advice from somebody else, right? You're going to hear somebody who struggled getting in to medical school and they're going to say, man, I wish I went to a BSMD program because I would have just gone straight in, right? So everyone's experience is different. And what's important is hearing out those experiences, getting general advice and tailoring that advice to how it fits for you, right? And I always tell people this, advice is a zero-sum game. So if you got advice from every single person in this world about something, it's all going to cancel each other out, right? So I tell people to beware of asking too many people or thinking of too many thoughts when it comes to decision making, because it's going to cancel everything out. But what you have to keep in mind is try to get the advice that's relevant to you, personalized advice, ask specific questions to people. That's the best way that you're really going to figure out, if there's a fork in the road to go left or right. Do you have a YouTube channel or some other platform? I love listening to you talk so far. I appreciate it. I don't have a YouTube just because I don't have time, but I do have Instagram, which I'm pretty active on. My handle is at dr.darsh. So doctor spelled out .darsh. Also, if you go on the Web Shadowers Instagram page and you see the post that they put up to promote this, you'll see my handle on there. Let's see. So I'm going for my Bachelor of Science in Neuroscience. Do you think this is a good major? Oh, this is a great question because I love talking about majors in as a pre-med. So again, my advice is to not do anything science related as an undergrad. Again, I had to do biology. Even if I wasn't forced to do something like biochem, or chemistry, I probably would have picked bio because I think that's what we all are ingrained to think when we go to medical school: biochem, chemistry, neuroscience, those types of things, right? Kinesiology. Now, obviously, there's going to be some people who are like, nope, I'm going to do economics or I'm going to do these things, which is awesome. And I applaud people to do that. If I could go back, I would not have been a science major. And the reason why is, one, I don't think there's anything that you learn in undergrad that truly helps you for medical school. Maybe anatomy and physio a little bit. It might have helped me not study for it probably cut off 2 hours of my studying time, right? Which is like nothing. So I think it's very important to realize that you're going to be doing science for the rest of your life, right? If you choose healthcare or medicine, you're going to do it for the rest of your life. Most of the stuff that you're learning in undergrad isn't truly helping you for you can self-study the MCAT too, right? So essentially what I did, I went to Temple University, and not to bash on it, but didn't really help me for the MCAT. I self-studied. But if I did economics, if I did computer science, if I did philosophy, if I took something that I was just like, hey, I have 4 years left to just learn whatever the hell I want to, I would have done that. It would have developed me as a person. It would have made me more interesting. I would have had some cool knowledge about something, that other people truly don't. And it doesn't look bad when you apply to medical school. So I want to really dispel that myth. Med schools aren't looking for people just who apply to sciences, right? And it's also not just an advantage if you're an economics major. But you have to choose something that you're interested in. And again, if you're super passionate about sciences and things like that, go for it. I just don't think most pre-meds are. I think most of us choose it because it's what we're told to do and we see other people do it. So for that reason, I would 100% personally, I would have done probably econ because I realized wow, I'm actually kind of interested in business and how it all works. And then obviously I would have done like a bio minor just to get all the classes in. So that's my spiel on that. When I go live, I talk about that often about the major. Let's see. Do you mostly only work? All right, 1 second. So that question about the major, they also said, I already know I wish I want to get into anesthesiology. So whatever you choose to go into, like whatever field you're interested in, nothing in undergrad is going to help that, right? That's going to be all strictly residency into your or medical school into residency. So I wouldn't even correlate your pre-med classes to whatever you're going to learn later on. They're not connected. Okay. Do you mostly only work with patients who are elderly, or have you worked with children as well in the past? What was the differences of your experience in both eyes? So I haven't worked with children yet. So PM&R is a very encompassing field. I mean, we work with children who have cerebral palsy to trauma all the way up to elderly patients, right? So I have a patient who's like 97 years old right now, had a stroke. I haven't done peds though yet. I've done like general pediatrics as a medical student. But the reason I chose PM&R is because you have the opportunity to motivate patients, essentially be not only their doctor, but their life coaches, right? And try to motivate them to say, hey, we're going to get you back to where you need to be. And we're going to make you as independent and as strong as possible. And for me, like, I love mentoring. I love coaching. Hopefully, as evident as you guys can see on here, I'm super passionate about giving, try good advice and personalized advice to people. And to do that with patients on a daily basis is just like heaven for me, right? It's awesome. So again, I haven't worked with peds yet. I'll do that next year. But so far, it's been awesome working with all sorts of age ranges. You know, I've had 20-year-old patients all the way up to 97, like I said. So it's good diversity. Let's see. I think I only have like 4 or 5 minutes here. So I just started first year pharmacy school, but I'm on the verge of switching to medicine because of my love for physiology and biochem, but I'm hesitant that I will not get in because of low GPA and possible low MCAT. So you have to choose what you're willing to do, okay? There are Caribbean schools out there. And I think most of you guys know about these Caribbean schools like St. George's or Ross, American University, things like that. They usually take people with lower scores, right? That's what they're known for. Does that necessarily mean you're going to be a bad doctor? No, not at all. I have worked with people from the Caribbean schools who are great, better than me. So yes, it's tough, right? Because you're in the Caribbean, it's not as personalized, one-on-one attention, all those things. It is tougher to get into residency. But if you are determined and you are 100%, you want to become a physician, but you can't get into an MD or DO school, which I would say is first preference if you are going to apply. At least apply once or twice before applying to Caribbean schools, is what I would say. Then you go to a Caribbean school if you can't get in, and you work your butt off, you do well in your exams. Although now that step 1 is pass fail, I don't know how things are working out. We'll see what the trends are for this year, next year, and the year after that. I have no idea. So, but there are options, is what I'll say. If you're truly passionate and gung ho about doing becoming an MD or DO. Okay. Also wondering what's your IG? Again, Dr.Darsh, doctor spelled out. Thanks for responses. Do you think it's a good idea to get a dual degree, getting 2 bachelors, if it's only an extra year of school? I mean, if you're passionate about it, yeah, why not? Like if you really want to take courses. So I wouldn't even think about it in terms of degrees. I would think about it in terms of courses. Are you super interested in taking those extra, whatever, how many courses it is? If it is, awesome. If the end result of that is getting another bachelor's, cool. But think about it in terms of what you're interested in rather than what the outcome is, right? Because again, big picture, your goal is to become an attending physician, right? That's big picture. You need to focus on what's going to help you get to that and help you become the best attending physician that you can be. And the best attending physician you can be isn't necessarily about the best school. It's not about the best research. It's about being the best version of yourself, right? It's about how do you improve every single day as a doctor? I know physicians who came from Harvard, Cornell, all these things that honestly are just not great physicians that I've worked with. And I'm just like, man, like it doesn't matter where you go. It matters who you are and how you want to make a difference, honestly, and how you create value for your patients and for your team and for yourself. And you really want to focus in your 20s, that growth is what's going to help stimulate you to become the best version of yourself and the best physician or best whatever occupation you're going to choose. And you're going to see that you're going to be more fulfilled in life just with that. Okay, so sorry I can't get through all the questions. Again, message me on Instagram. I reply to everybody. So at dr.darsh, that's where I do all my communicating. This was awesome. I really appreciate you guys having me on here again. I love doing these Q&As. Hope you guys got some knowledge out of the case presentation as well. Best of luck to everyone. So I'll let you guys take the floor again. Thanks.
Thank you so much, Dr. Shah, for coming back and sharing your knowledge with our web shadowers. This was an awesome session. Thank you.
Yeah, absolutely. Thank you.
Everyone, make sure you check out his socials and his podcast. His Instagram is dr.darsh.
The link to the Google form will now be posted in the chat, so please fill it out within the next 30 minutes for us to receive your attendance. And again, thank you so much, Dr. Shah. We love how personable this session was and all the advice you gave.
Absolutely.